Assalamu alaikum. I am Hafiz Ahmadullah. Today we are going to start a series of lecture covering testicular cancers. Today is the introductory lecture. My moderator is Dr. Mehnaz Jabin. The objectives of today's presentation are to discuss about the epidemiology, etiology, classification, clinical features, investigation, and staging of testicular cancers. Uh, Anatomy of the testes. The testis is the male gonad. It is homologous with the ovary in female. It lies obliquely within the scrotum, suspended by the spermatic cord. The left testis is slightly lower than the right one. It measures about 3.7 into 2.5 into 1.8 centimeter and weighs about 10 to 15 grams. It has two poles, which are superior, inferior, two surfaces, anterior, posterior, and two borders, medial and lateral. The coverings of testes from outward to inward are skin, dartos muscle, uh, external external spermatic fascia, cremasteric muscle, internal spermatic fascia, tunica vaginalis, and tunica albuginea. The retitestes is a network of tubules located in the hilum of testicle that carries sperm from seminiferous tubules to the efferent ducts. Retitestes give rise to 12 to 30 efferent ductules. Epididymis is a long tube about 20 feet that is coiled on the posterior surface of each testis. It connects efferent ducts to vas deferens. Ductus deferens extends from the epididymis in the scrotum on its own side into the abdominal cavity through the inguinal canal. The blood supply of the testes. Arterial supply is from the testicular artery, which is the branch of abdominal aorta. The testes has a collateral blood supply from the cremasteric artery and the artery to ductus deferens. The veins emerge from the back of the testes and receive tributaries from the epididymis. They unite and form a convoluted plexus called the pampiniform plexus. The plexus eventually forms a single vein which opens on the right side into IVC and on the left side to the left renal vein. Lymphatic drainage. The primary drainage of the right testes is within the interaortocaval region. The left testes drainage is to the para-aortic region in the compartment bounded by the left ureter, the left renal vein, the aorta, and the origin of inferior mesenteric artery. The crossover from the right to left is possible. Starting the introduction to testicular cancers, testicular tumors are rare, 1 to 2% of all malignant cancers, and most common malignancy in men in the age of 15 to 35 years. Benign lesions represent a greater percentage of cases in children than in adults. These are most curable solid neoplasms. Testicular cancer is one of the few neoplasms associated with accurate serum markers. As already told, most curable solid neoplasm and serves as a paradigm for multimodal treatment of malignancies. Epidemiology is most common between these are most common between ages of 15 to 55 years. Incidence rapidly rises after puberty, as you can see in the graph, peaking at the age of 25 to 35 years. Incidence varies greatly according to geographical region, and the rates are highest in Scandinavia, Europe, New Zealand, Australia, intermediate in USA and UK, and lowest in Africa and Asia. The etiology of testicular tumors. Factors include undescended testes, intersex disorders like Klinefelter syndrome, testicular atrophy, trauma which prompts medical evaluation, chromosomal abnormalities like loss of chromosome 11, 13, 18, and abnormal chromosome 12p. Sex hormone fluctuations, for example, estrogen administration during pregnancy, race, carcinoma in situ, previous testicular cancers. These are testicular tumors are classified into primary tumors, secondary tumors, and paratesticular neoplasms. The primary tumors include germ cell tumors and non-germ cell tumors. Germ cell tumors are divided into seminomas and non-seminomas. Non-seminomatous germ cell tumors include teratomas, embryonal carcinoma, choriocarcinoma, yolk sac tumor, and mixed tumors. Non-germ cell tumors include Leydig cell tumor, Sertoli cell tumors, gonadoblastomas, and others which include adenocarcinoma of fatty testes as well as carcinoid tumors. The secondary tumors are lymphomas, leukemias, and metastatic tumors. And another category is paratesticular neoplasms. Germ cell tumors comprised of 40% of these comprise seminomas, and embryonal carcinomas make about 20 to 25%. Teratomas make about 25 to 35%, and these are further divided into mature and immature teratomas. Choriocarcinomas make about 1%, yolk sac tumors, and spermatocytic tumors. Non-germ cell tumors include specialized gonadal stromal tumors, which include Leydig cell tumor and Sertoli cell tumors, gonadoblastomas, and miscellaneous, which include carcinoid tumors and tumors of ovarian epithelial subtypes. The germ cell tumors are most common in young age group. These have rapid rate of growth and good differentiation. These are both sensitive to chemotherapy and radiotherapy, and prognosis is good because of its response to chemo and radio. Germ cell neoplasia in situ. Uh, Most of the germ cell tumors arise from germ cell neoplasia in situ, with the exception of spermatocytic tumor. Germ cell neoplasia in situ consists of undifferentiated cells that have appearance of seminoma located basally within the seminiferous tubules. Seminomas are most common testicular tumors. The peak incidence is in fourth and fifth decade. Patient presents with a painless testicular mass. Uh, Immunohistochemistry is negative for CD30 and positive for CD117 and placental alkaline phosphatase. Serum AFP is usually normal, although in some cases about 15% beta Hg can be raised. Microscopically, soft tan to white diffuse multinodular masses, and microscopically these appear as sheet-like arrangements of cells with polygonal nuclei and clear cytoplasm, with cells divided into nests by fibrovascular septa that contain lymphocytes. Syncytiotrophoblasts, which stain positive for HCG, can be identified in 15% of cases. Spermatocytic tumor is a benign tumor with peak incidence in sixth decade of life. Unlike other GCTs, it does not arise from germ cell neoplasia in situ and not associated with history of undescended testes. Histopathology differs from seminoma in that they do not stain for placental alkaline phosphatase or glycogen stain. Microscopically, nuclei are round, minimal lymphocytic differentiation. Embryonal cell carcinomas are second most common germ cell tumors. These are aggressive tumors and often with high rates of metastasis, often in context of normal tumor markers. These are most undifferentiated types of non-seminomatous germ cell tumors with totipotential capacity to differentiate to other non-seminomatous germ cell tumor types within the primary tumor and metastatic types sites. These typically stain for placental alkaline phosphatase, AE1, AE3, OCT3 and 4. Uh, Macroscopically, they appear tan to yellow neoplasm with often large areas of hemorrhage and necrosis and greatly varies microscopically. Choriocarcinomas are a rare and aggressive tumors. 5 year survival is 5%. Typically present with elevated HCG, presents with disseminated disease and metastasis to lungs and brain. Primary is very small and often exhibit no testicular enlargement. Small palpable nodule may be present. These are prone to hemorrhage, sometimes spontaneously uh, in the metastatic sites that are lungs and brain. Catastrophic hemorrhage immediately after chemotherapy may occur. Uh, Macroscopically, the primary lesion may be a hemorrhagic or a clotted mass in which bits of gray tumor can be seen and presents as nodules. Microscopically consists of both syncytiotrophoblasts and cytotrophoblast. Prominent areas of hemorrhage and necrosis are seen. Yolk sac tumor are most common germ cell tumors and most common testicular tumors in children, where it occurs in its pure form. In adults, it is unusual in pure form but is found approximately 50% of mixed germ cell tumors. Testicular mass is the most usual presentation and always produce AFP and never HCG. These are easily detectable with lower relapse. Macroscopically, yolk sac tumors appear white to tan masses with myxoid and cystic changes, and microscopically, a reticular network of medium-sized cuboidal cells with cytoplasmic and extracytoplasmic eosinophils. Glandular, papillary, or microcystic patterns can be seen. Schiller dual bodies are characteristics. Like in the diagram, Schiller dual bodies are uh, structures that comprise of a central vessel surrounded by tumor cells. Teratomas Teratoma in Greek means monster tumor and occur in its pure form with a mean age of diagnosis at 20 months. In adults, these occur as component of mixed germ cell tumors and are identified in more than 47% of mixed tumors. Pure teratomas are uncommon. Uh, they have usually normal serum markers, maybe mildly elevated AFP levels. Macroscopically, they appear largely depends on elements within it with solid and cystic areas and microscopically contain more than one germ cell layers, uh, ectoderm, endoderm, or mesoderm. These range from mature with well differentiated tissue to immature with undifferentiated primitive tissues. These composed of somatic types of tissues that include enteric type glands, respiratory epithelium, cartilage, muscles, hair, etc. Immature teratomas contain immature neuroepithelium, blastemas, or cellular stroma. They can give rise to carcinoma such as adenocarcinomas or sarcomas such as rhabdomyosarcomas. Growing teratoma syndrome is they they may grow uncontrollably, invading the surrounding tissues and become unresectable. And teratoma with malignant transformation are, as already discussed, rarely teratomas can transform into somatic malignancies such as rhabdomyosarcomas, adenosarcomas, or primitive neuroectodermal tumors. So the signs and symptoms of testicular cancers are the most common sign or symptom is painless testicular mass. Acute testicular pain is caused by intratesticular hemorrhage or infarction. Patient may complain of vague scrotal discomfort or heaviness. The symptoms are related to that are related to metastatic disease are the presenting complaint in 10 to 20% patients. The bulky retroperitoneal metastasis may cause a palpable mass, abdominal pain, flank pain resulting from ureteral obstruction. Back pain because of the involvement of psoas or nerve roots. Pulmonary metastasis may present with dyspnea, chest pain, cough, or hemoptysis. Approximately 2% of men have gynecomastia, resulting from either elevated serum HCG levels, decreased androgen production, or increased estrogens. On physical examination, examination of the affected and normal contralateral testes both are necessary, noting their size and consistency and palpating any testicular or extra-testicular masses. Atrophy of the affected or contralateral testes is common, particularly in patients with undescended testes. Any firm area within the testes should be considered suspicious for malignancy and should prompt further investigations. Examination for evidence of palpable abdominal mass or pain, inguinal lymphadenopathy, gynecomastia, and supraclavicular lymphadenopathy should be done.
Any question?
Differential diagnosis includes epididymoorchitis, testicular torsion, hematoma, paratesticular neoplasms, hernia, varicocele, spermatocele. A firm intratesticular mass should be considered cancer until proven otherwise. Hydrocele can be a presenting sign of the testicular cancer as well. So diagnostic delay. Prior studies show up to one third of testicular tumors are initially misdiagnosed as epididymitis and hydrocele. For patients with metastatic signs and symptoms, these may be the focus of the physician treating the patients. The interval of delay is associated with advanced clinical stage, suboptimal response to chemotherapy, and diminished survival rate. Diagnostic testing includes scrotal ultrasound, magnetic resonance imaging, serum tumor markers, and radical inguinal orchidectomies.
Differentiate between the tumor and other differential diagnoses you have seen. On clinical examination. Anyone? Yes, Noman.
First of all, by taking the history, most of the testicular tumor are painless mass, or sometimes they are incidental finding after the general evaluation of testis after trauma or any infection. When you palpate the physical the testis during the genital examination, you feel the lump, or if the mass is palpable, it is non-tender. It is most probably until unless proven otherwise, it is testicular tumor. If it is orchitis, it can cause pain. It is warm. It's tender on the skin. Other signs and of the inflammation will be there, and the urine culture will be positive on the diarrhea. And if there is a hematoma or abscess, there might be a symptom, the sign of fluctuancy, uh, the cystic nature of that thing. If on the patient is presenting with the metastatic disease or with the other sign like abdominal mass or back pain, and he is in the puberty age, and we are suspecting that he might have the testicular tumor, then we can differentiate from ultrasound imaging of the testes. We see the a echogenic mass inside the testes, or at the level which we cannot palpate with suspicion. A hydrocele can be if there is a hydrocele and we are suspecting, we want to differentiate between a testicular tumor and hydrocele. First of all, on the clinical examination of hydrocele, we see the huge scrotal swelling on one side, on both side, and we check the illumination test, QNC, and ultrasound. We find that in the testicular pain camera there is no increased vascular area, just there's this clear fluid. And on the abdominal examination, we might see the protuberance of the abdomen and the hard mass inside the abdomen, while deep palpation, visual palpation of the abdomen. And patient might have the symptoms of vomiting and back pain and lower leg pain and cachexic nature. And on the serum investigations in blood invest, if we are suspecting that the patient is
What
having
is
the
the
mass
relation of trauma?
trauma, after the trauma, the diagnosis of testicular tumor is mostly incidental. Trauma cannot cause a tumor, but trauma can lead to the diagnosis of testicular tumor during the further evaluation of genital areas.
Exactly. 90% will present with the trauma, that after trauma they develop swelling, but it's not necessary that it's because of the trauma. Maybe they noticed about trauma after trauma. Sorry.
And there was one thing written in the slide, the inguinal lymphadenopathy. You should check for the linguinal lymphadenopathy. If the patient is having a scrotal mass and he is also having this inguinal lymphadenopathy and is not having other sign and symptoms of UTI or other, there is no inflammatory process going on in lower extremities, it means that the tumor is already crossed the scrotal lymphatic channels. And there is one thing also, the choriocarcinoma, it is very rare, and the difference between other testicular tumor, germ cell, non-germ cell, and the choriocarcinoma is that the testicular germ cell tumor, uh, they metastatize through lymphatic channels, but the choriocarcinoma,
Which
it
lymphatic
metastasizes
channels?
hematogenously.
Testicular tumor metastasize to which lymphatic channels? Paralytic. But why we should check the superficial inguinal lymph node? Because it's not present there.
It's not.
Why?
The lymphatic drainage of testes is separate and the scrotum is separate.
Exactly. Both is
Scrotal
separate.
lymphatics, they drain into the why the inguinal lymph nodes to the cisterna chyli. But the testicular lymphatics, they drain from the just around the from the spermatic cord, retroperitoneum, in precaval, paracaval, interior to caval lymph nodes, cisterna chyli, then to the mediastinum and the heart.
Yes. So keep, and you should look for that on examination, especially.
Scrotal ultrasound. In men with a scrotal mass, hydrocele, or unexplained scrotal symptoms, scrotal ultrasound should be considered an extension of physical examination. With high frequency transducers, intratesticular lesions as small as few millimeters can be identified and can be distinguished from extratesticular pathologies. Typical germ cell tumor is hypoechoic, and two or more discrete lesions may be identified. Heterogeneous ecotexture within a lesion is more commonly associated with non-seminomatous germ cell tumors. The risk of malignancy increases with the size of lesion, from 50% to lesions smaller than 1 centimeter and 80% for lesions 1 to 2 centimeter. In cases in which the sonographic findings are equivocal or suboptimal, MRI is a helpful tool to distinguish between testicular versus extratesticular lesions and neoplastic versus non-neoplastic lesions. Serum tumor markers are testicular tumors are one of the few malignancies associated with serum tumor markers. These include LDH, AFP, and beta HCG. Tumor markers should be obtained at the time of diagnosis, after orchiectomy to monitor for relapse in patients on surveillance, and after completion of therapy. So, seminomas, seminoma may present with increased LDH and increased HCG. In York sac tumors, AFP is usually raised. In choriocarcinomas, beta HCG is usually raised. Embryonal carcinoma may have raised AFP, beta HCG, and LDH. Whereas in teratomas, uh, none of them usually is raised.
So, what if all tumor markers are negative, like in teratoma? What will you do? What next? Anyone? How many of you have done your onco clinics? No one. Most of you have done. Nobody know about it. How? On which basis? If there is increased vascularity on ultrasound CTF. Exactly. So this is simple. If you are still in a doubt, you can go for the CT scan as well. Okay.
Alpha fetoprotein has normal value of about less than 16 nanogram per ml. Its half-life is 5 to 7 days, and raised AFP is seen in embryonal cell carcinomas, York sac tumors, and teratocarcinomas. Beta HCG has a normal value of less than 1 nanogram per ml. Its half-life is 24 to 36 hours. Raised beta HCG is seen in choriocarcinoma, embryonal cell carcinomas, teratocarcinoma, York sac tumor, and seminomas. LDH is expressed in smooth cardiac and skeletal muscles. Its half-life is 24 hours. It is elevated in approximately 20% of low-stage germ cell tumors and 60% of advanced germ cell tumors. It is the result of tumor marker assays. The result of tumor marker assays should not be used to guide decision making about whether to perform a radical orchidectomy or not, because AFP or HCG levels in the normal range don't rule out germ cell tumors. Radical inguinal orchidectomy. Suspected testicular neoplasms should undergo radical inguinal orchidectomy with removal of tumor-bearing testicle and spermatic cord to the level of deep inguinal ring. It establishes histopathological diagnosis, and primary T-stage provides important prognostic information from testicular tumor histology. The clinical staging, prognosis and initial management decision are dictated by the clinical stage of disease, which is based on histopathological findings, pathological stage of primary tumor, post-orchidectomy serum tumor marker levels, presence and extent of metastatic disease. The clinical staging of abdomen and pelvis is done by CT imaging with oral and IV contrast. It is most effective, non-invasive for the staging of retroperitoneum and pelvis. A size cut of 10 mm is frequently used to identify enlarged lymph nodes. Retroperitoneal lymph nodes between 5 to 9 mm in size in the primary landing zone should be viewed with suspicion for regional lymph node metastasis. Malignant germ cell tumors accumulate FDG, and several studies have investigated FDG PET in the staging of GCT at diagnosis and assessing response after chemotherapy. All patients with germ cell tumors should undergo chest imaging before management decisions. The thoracic metastasis in the absence of retroperitoneal disease or normal serum markers is uncommon. Serum tumor markers. The presence of newly elevated and or rising serum tumor marker levels after orchiectomy indicates the presence of metastatic disease and these patients should receive chemotherapy. Pre-chemotherapy serum tumor markers levels are: SX is serum marker studies not available or not performed. S0 is serum tumor marker study levels within normal limits. S1 is LDH is less than 1.5 times normal, and HCG is less than 50,000 million international units per ml. S2 is 1.5, LDH is 1.5 to 10 times normal, or beta HCG is 55,000 to 50,000 million international units. S3 is LDH more than 10 times normal, or beta HCG more than 50,000 million international units. The TNM staging of testicular cancers include T stage, that is primary tumor, and N regional lymph nodes, clinical and pathological, and M distant metastasis, and S serum tumor markers. Uh, T includes PTX, that is primary tumor cannot be assessed. PT0 is no evidence of primary tumor. PTIS, intratubular germ cell neoplasia. PT1 is tumor limited to testes and epididymis without lymphovascular invasion. It may invade tunica albuginea but not tunica vaginalis. PT2 is tumor limited to testes and epididymis with lymphovascular invasion or tumor involving the tunica vaginalis. PT3 is tumor invades the spermatic cord with or without lymphovascular invasion. PT4 is tumor invades the scrotum with or without lymphovascular invasion. Regional lymph nodes and clinical are NX. Regional lymph nodes cannot be assessed. N0, no regional lymph node metastasis. N1 is metastasis within one or more lymph nodes less than 2 centimeter in size. And N2 is metastasis within one or more lymph nodes greater than 2 centimeter but less than 5 centimeter in size. N3 is metastasis within one or more lymph nodes greater than 5 centimeter in size. Pathological N is NX. Regional lymph nodes cannot be assessed. N0, no regional lymph nodes metastasis. N1 is metastasis within 1 to 5 lymph nodes, all nodes masses less than 2 centimeter in size. N2 is metastasis within a lymph node greater than 2 centimeter but not greater than 5 centimeter in size, or more than 5 lymph nodes involved, none greater than 5 centimeter, and none demonstrating extranodal extension of tumors. And 3 is metastasis within one or more lymph nodes greater than 5 centimeter in size. M includes MX, that is distant metastasis cannot be assessed. M0, no distant metastasis. M1 is distant metastasis, which includes M1A and M1B. M1A is non-regional nodes or pulmonary metastasis, and M1B is distant metastasis at other than non-regional lymph nodes or lungs. Serum tumor markers, S. SX is tumor markers not available or not performed. S0 is markers are within normal limits. S1 is LDH less than 1.5 times normal. HCG less than 5,000 international units per liter. AFP less than 1,000 nanogram per ml. S2 is LDH 1.5 to 10 times normal. HCG between 5,000 to 50,000 international units per liter. AFP between 1,000 to 10,000 nanogram per ml. LDH, S3 is LDH more than 10 times normal. HCG more than 50,000 international units per liter. AFP more than 10,000 nanogram per ml. Guidelines for diagnosis and staging of testicular cancers. Uh, the poor serum quality is frequently found in testicular cancer patients before and after treatment. Semen preservation is the most cost-effective strategy for fertility preservation. Serum tumor markers, including AFP, beta HCG, LDH, should be determined before and after orchiectomy and throughout follow-up. They are used for accurate staging, risk stratification, and to monitor treatment and to detect relapse. For abdominal staging, contrast enhanced CT has a median sensitivity, specificity, positive predictive value, and negative predictive value, and accuracy of 67%, 95%, 87%, 73, and 83% respectively. Sensitivity decreases and specificity increases with increasing lymph node size. For chest staging, contrast enhanced CT has a median sensitivity of about 100%. Contrast enhanced computerized tomography and MRI are key image modalities for the detection of brain metastasis. Magnetic resonance imaging is far more sensitive than contrast enhanced CT, though it does requires expertise. FTG PET has a limited diagnostic accuracy for staging before chemotherapy. There are no high level evidence studies supporting screening programs and intestinal sparing surgery. Uh, Frozen section has shown to be reliable and highly concordant with final histopathology. There is no evidence supporting any size criteria for a testicular lesion to be safely followed up, and in patients without risk factors, there is low incidence of contralateral germ cell neoplasia in situ and metachronous germ cell testicular tumors. The recommendations include
So the diagnosis and the staging is very important in testicular tumor. What we see usually, the medical oncologist is very happy to see these tumors. Why? Anyone knows the reason? मेडिकल ऑन्कोलॉजिस्ट को जब आप ये ट्यूमर का पेशेंट देंगे तो वो खुशी से देखता है और उसको he wants to treat the patient. मतलब
The testicular tumor, they are the most curable tumor, and they are the success landmark for medical oncology. After uh, uh, the knowing of cisplatin chemotherapy, and the reason in this, they can be cured completely with just chemotherapy, and they are radio sensitive also. But radiation nowadays, we are not giving radiation nowadays because of its cumbersome other effects. But the other reason of chemotherapy sensitivity is that the germ cell tumor and the germ cells which are receiving the chemotherapy is flatten based. They don't have the pusher in every cell when they are tumor cells which is receiving chemotherapy. The tumor cells are very sharp. Whenever they receive that chemotherapy agent, and they push that chemotherapy outside that cell, like in RCC when we are giving, and the cisplatin has very minimum role in renal cell carcinoma. Whenever you give the cisplatin, the tumor cells, they have the pusher and they have the adductor also. They push the chemotherapy agent outside the tumor cells, so that that chemotherapy agent doesn't have any catastrophic effect on the tumor. But in germ cell tumor, once that you are giving the chemotherapy, the agent, it enters that germ cell tumor, and the tumor is not having any potential to push that agent outside that germ cells. So they completely destroy that tissue. But there are other things that in testicular tumor, like you are giving the chemotherapy in non-seminomatous germ cell tumor, metastatic or just stage 1 disease. We don't have any other modality, like we cannot see on contrast and on imaging or on FTG PET, like in non-seminomatous, that there is any residual tumor present or not. Because whenever there is a necrosis or whenever there is an apoptosis, the tumor cells, they differentiate into the fibrosis, necrosis, or they can convert into teratoma. But we cannot distinguish between teratoma, fibrosis, or necrosis present in the retroperitoneum. So the needle core biopsy or FTG PET, they have no role in non-seminomatous germ cell tumor. So this
so
is a
even
success landmark.
this is the most
Curable
chemo sensitive tumor among the urological all tumors. This is the most chemo sensitive, even with the metastasis.
Yes.
Even if the patient comes to you with a brain metastasis and you offer them upfront chemotherapy, then there is a dramatic response of this tumor.
I have one question. Uh, is there any role of a semen analysis in the tumor?
In it is written in the literature and in the books that the patient who is having the testicular tumor or the mutation germ cell neoplasia NC2 or any mutation in chromosome 12YP, they always had the changes in their semen quality, and it is already present before the radical orchidectomy or chemotherapy. But after giving chemotherapy, because it passes through the testicular blood barrier, it can decrease the semen quality. So what we
Semen
maximum
quality or sperm quality?
sperm quality, what we can do maximum is before radical orchidectomy or just after radical orchidectomy, we ask the patient to go for the sperm banking.
Exactly. So this is
Because-
very important. If the patient is having bilateral testicular tumor, what will you do then? Sorry, I can't hear you.
Basically, it all depends on the patient, what he's willing. Is he planning to become a parent? And then we counsel the patient that we can do cryopreservation. We can do, as Donoman mentioned, sperm banking. But at the beginning, everything starts with the patient. We have to consult the patient that you have this tumor. And as he said, that the tumor by itself presents with the quality of the sperm decreasing even before giving the chemo radiation. And after the giving the chemo radiation, especially the radiation, that it decreases the quality and the quantity of the sperm decreases tremendously, and the patient has high chance of becoming infertile. So
But
usually,
after chemo, it's a very high chance to
Yes.
become infertile. So you have to counsel the patient.
the chances of regaining after 2 years is also there. We have to tell them that after the radiation, after 2 years of radiation, patient might become fertile again, even if there is no sperm banking. There is a chance. Yes.
After radiation,
Yes.
what if you have given him a chemotherapy?
Even chemotherapy, also the chance is very less. Always
Then-
for the safe side is to have a
But that
sperm
will be
banking.
decided by the oncologist, not by us. So you have to counsel. You are going for a cardiectomy, so you should decide first, and you are the first one who face the patient. So you should counsel the patient that these are the chances and these are two options. But the most common option given by the oncologist is chemotherapy. 70 to 80%. So you should also tell them that if you want to go for the sperm banking, you should go early. Okay. So this is very important because most of the patient present in early ages. How many have you seen patient above the 50s or 60s?
we,
कोई तो बता दो
we
इतने
have
सारे
seen the
लोगों को।
patient of old age with testicular malignancy, but mostly but every time when we see the old patient with testicular mass and it is malignancy, then it is lymphoma mostly. But in pubertal age, it is
लेकिन उसमें भी तो आप कीमो ही देते हैं ना।
उसमें भी chemo देते हैं।
फाइनल वही
After
कीमो
all
की
chemo।
बात आ गई ना। अब तो कीमो की बात कर रहे हैं ना कि आखिर में जब कीमो आ रही है तो पेशेंट को तो आपने बताना है ना।
बिल्कुल।
अब नहीं बताएंगे। यंग पेशेंट आपके पास ज्यादा प्रेजेंट हो रहे हैं, ये अर्ली टेराटोमा सेमिनोमा दोनों अर्ली है ना। तो आपको कीमो के बारे में जब आप जानने की बात करेंगे, 90% आपके जो है ना ऑन्कोलॉजिस्ट कहेगा कीमो देनी है, तो आपको तो बताना है पेशेंट को। वो आपसे एक्सपेक्ट कर रहा है क्योंकि आप फर्स्ट वन है, आपने उनको काउंसिल किया। हो सकता है वो रेडियोलॉजिस्ट ऑन्कोलॉजिस्ट की बात ना समझ पाए, मगर आप तो पहली चीज बंदे हैं जिससे मिल रहे हैं, जिसके साथ बैठ रहे हैं। अगर आप गलत काउंसलिंग करेंगे तो वो नहीं समझेगा बात को आगे भी। तो स्टार्ट ही अच्छे से लेना, इसीलिए डायग्नोसिस वेरी इंपॉर्टेंट। इसीलिए सारे जो है ना मेजर्स करने चाहिए। ठीक है, इज वेरी इंपॉर्टेंट फॉर द पेशेंट एंड योर सेफ्टी एज वेल।
So the TNM staging Not like other tumors in TNF stage testicle cancer. The T stage is always pathological. It is almost always after the radical orchidectomy. And the nodal size and metastasis it is on imaging radiological modality.
बेसिकली आफ्टर कार्डियक्टमी हम जो है टीएनएम क्यों करने की कोशिश करते हैं, टी तो वहीं से शुरू हो गया जब आपके पास ट्यूमर आ गया, लेकिन हमें चूंकि आगे आरपीएलएनडी के बारे में सोचना होता है इस वजह से, ठीक है। वरना आपको ज्यादातर अगर आप कहीं और कहेंगे तो वहां ऑर्किडेक्टमी डायरेक्ट नहीं होती, वहां वो कहते हैं कि आप पूरा स्कैनिंग करके करें, ठीक है। तो दो स्कूल ऑफ थॉट है, कुछ कहते हैं ऑर्किडेक्टमी पहले कर दें और हो सकता है मेटास्टेसाइज उसमें हो, क्योंकि ट्यूमर मार्कर अगर ज्यादा बड़े हुए होंगे, बेसिकली हम ट्यूमर मार्कर को देख के चल रहे होते हैं 90% ना, इसलिए।
सो एनी अदर क्वेश्चन? नोमान के
इलावा
को हटा के, ठीक है, सारे क्वेश्चन नोमान की तरफ से आ रहे हैं और सारे कमेंट्स भी उनकी तरफ से आ रहे हैं।
I
तो
have a-
मान ने क्लिनिक किए लगता है।
For staging work, usually we go for the CT, chest, abdomen, and pelvis to see the lung window, to see the mets in abdomen for retroperitoneal lymph node. When we go for, when we decide for MR pelvis, and the other thing is FDG PET when it comes, just to see the chemotherapeutic response, to see the metastasis, or to see the size of the mets.
Is this a question or explanation?
So it's my question that when we go for the MR pelvis, usually we go for the CT chest, abdomen, and pelvis. And when we decide that we should go for MR pelvis rather than CT chest
You
and
have
abdomen.
done a lot of clinic, if I'm not wrong, Arslan. So if you have seen in the initial phase, you go for the CT scan. बट पेट एफटीजी जो आप बता रहे हैं वो सेकंड स्टेज में आता है बेसिकली आफ्टर व्हेन यू हैव गॉन फॉर द आरपीएलएनडी और कीमोथेरेपी रिस्पॉन्स, स्पेशली आफ्टर कीमोथेरेपी नॉर्मली वो करते हैं ताकि वो देख सके क्यों करते हैं। पहला तो सवाल है वो करते ही क्यों है, बताएं।
PET scan, this is basically uptake to see the met size that is chemo has responded or not.
वायबल ट्यूमर्स देखने के लिए, ठीक है, कि अगर उसमें आपको वो पॉजिटिव आता है तो आप कहते हैं कि देयर इज चांसेस ऑफ वायबल ट्यूमर, देन यू गो फॉर द आरपीएलएनडी अगेन। यही होता है ना, आप एफडीजी करा के देखते हैं, उसके बाद आपको पेट स्कैन के बाद आपको पता चलता है कि उसमें फिर भी जो है ना लिम्फ नोड्स कुछ पॉजिटिव आ रही है, वो अपनी पूरी कीमो देने के बाद आखिर में कहते हैं दिस इज द लास्ट ऑप्शन। देयर आर टू ऑप्शंस ओनली इन द टेस्टिकुलर ट्यूमर, लाइक आइदर यू गो फॉर द कीमोथेरेपी और देन यू गो फॉर द आरपीएलएनडी। ये दो ऑप्शन के अलावा कुछ भी नहीं मिलेगा आपको, ठीक है। तो एडवांस स्टेज पे अगर आप किसी को एक दफा आरपीएलएनडी करके दोबारा आरपीएलएनडी करने का अगर सोचेंगे तो डेफिनेटली आपको केयरफुल होके जाना पड़ेगा, क्योंकि एक सिर्फ ये नहीं है कि आपको ट्यूमर निकालना है, बाकी चीजें भी होती हैं उसमें, ठीक है। तो कॉम्प्लिकेशंस भी बढ़ती जाएंगी जितनी दफा आप पेशेंट को ओपन करके आरपीएलएनडी करते रहेंगे। फिर वही आती है हिस्टोपैथोलॉजी। अगर आपकी हिस्टोपैथोलॉजी ही ऐसी है जो कि बार बार रिकरेंस की तरफ जा रहा है पेशेंट, तो ये तो आपको पेशेंट को पहले ही काउंसिल करना पड़ेगा, ठीक है। एमआरआई लास्ट में आता है। फिर एमआरआई लास्ट में इसलिए आता है क्योंकि वो एक सॉफ्ट टिश्यू ट्यूमर को आइडेंटिफाई करने में मदद देता है आपको, जब आप बिल्कुल डाउट में होते हैं आपके वाकई में ये ट्यूमर रहा भी है कि अब नहीं है। तो इम्पोर्टेंस जो है वो एमआरआई की सबसे लास्ट में इसलिए आती है, इनिशियल स्टेज में हम नहीं कर रहे होते हैं। सबसे पहले हमें चेस्ट में मिलता है, चेस्ट में एमआरआई करके भी हमें कुछ मिलेगा नहीं। तो सीटी स्कैन लिम्फ नोड्स जो आइडेंटिफाई स्पेशली आपकी हो पाती है वो आपकी सीटी स्कैन पे ज्यादा अच्छी हो पाती है, इसीलिए सीटी स्कैन पे ज्यादा जाता है। बोन्स भी बता देती है वो, तकरीबन 90% आपकी चीजें वो उस पर आइडेंटिफाई कर देता है, ठीक है।
थैंक यू एवरीवन, थैंक यू।
Yes.
Like we open for hydrocele, and when we just open it and we find the testis like of course the testis looks like irregular and nodular, hard, suspicious of malignancy. Even in cases like with the diffuse scrotal swelling and history of past history of recurrent pain and suspicious of torsion, we opened it and we find some nodular sort of lesion in the somewhere near the cord that is compressing the vascular supply, giving intermittent ischemia sort of thing. In those cases, like those lesion that is suspicious of tumor, or even the testis that's looking like tumor, or how we should approach, like on table?
On table, if you are going for testicular torsion, this is your question. That if you are going for any surgery on the testes and you find some suspicious mass, you have two options. First option, you just close the patient and go again for the original diagnosis. Like if you didn't diagnose the patient on time, how can you go for anything else? Like आप एक्सप्लोरेशन कर रहे हैं टेस्टिस में, दोबारा अगर आप ऑर्काइडोपेक्सी भी किसी पेशेंट में सोच रहे हैं, किस बेस पे फिर सोच रहे हैं? ठीक है ना, 90% आप एक्सप्लोर करते हैं टेस्टिस को, क्यों खोलते हैं? टॉर्जन की वजह से खोलते हैं या किसी और वजह से, हाइड्रोसील की वजह से खोलते हैं, ठीक है ना? लेकिन पहली बात तो ये कि अगर आपने प्रॉपरली प्री सर्जरी जो है अगर डायग्नोज किया होगा तो ये चीज मिस तो होनी नहीं चाहिए। लेकिन फर्ज करें मिस हो भी गई, तो आप उसमें दूसरा काम ये कर सकते हैं, टिश्यू बायोप्सी तो कर सकते हैं ना, छोटा मास है बायोप्सी कर ले, बट वो ओपन बायोप्सी होगी, ठीक है? लेकिन उसमें फिर चांसेस वही होंगे लोकल, जो आप बायोप्सी करके जाएंगे डेफिनेटली लोकल के चांसेस जो है ना वो रहेंगे कि लोकली वो एडवांस हो जाए, क्योंकि बायोप्सी तो बाद में पता चलेगी ना, हिस्टोपैथोलॉजी 10-15 दिन के बाद आपको पता चल रहा है कि उसमें क्या आया है, लेकिन एज अर्ली एज पॉसिबल आपको उसको फिर डायग्नोज करके आगे चलना पड़ेगा, ठीक है? तो अगर छोटा है तो आप कर सकते, लेकिन यही कि आपको एक्सप्लेन फिर भी पेशेंट को करना पड़ेगा, कोशिश तो ये करनी चाहिए कि निकालें, ठीक है?
So thank you.
थैंक यू।
everyone. Thank you.